Dr. Dion Nelson, a naturopathic physician practicing in Portland, Oregon. I invite medical professionals to listen as I discuss how shifting the focus off of weight in healthcare can greatly improve health outcomes for patients of all sizes. I will explore what it means to practice in a weight-inclusive paradigm and discuss tools to implement these ideas in practice. Keep in mind that the information I will present may be new to many of my listeners and may sound radical to some, but stick with me. This information could change the lives of your patients. Welcome back, everyone. I had the opportunity to talk with Dr. Lesley Williams, who speaks regularly to fellow physicians about weight-inclusive healthcare and healthcare equity. And we talked about a whole bunch of different things. It was really an enjoyable time. She is a certified eating disorder specialist and board-certified family medicine physician. She received her Doctor of Medicine degree from the University of Kentucky College of Medicine and completed her family medicine residency training at the Mayo Clinic in Arizona. She has worked exclusively with eating disorders for over 15 years in the full spectrum of treatment settings. Dr. Williams recently established Williams Wellness Medical Group, an outpatient eating disorder focused medical practice in Phoenix, Arizona. She's also currently the medical team leader for Banner Behavioral Health Hospital in Scottsdale, Arizona. Say that 5 times fast. Her areas of expertise and interest include health equity and health at every size advocacy. Dr. Williams is a member of the American Academy of Family Physicians, and she was recently appointed to the Academy of Eating Disorders Diversity, Equity, and Inclusion Committee. Due to her hard work and dedication to the field, in 2018, Dr. Williams was named one of the top 80 female eating disorder leaders in the United States. Congratulations. I know you will all enjoy hearing from Dr. Williams as much as I enjoyed talking to her. So without further ado, here's our interview. Okay, so here we are with Lesley Williams, who's a physician in Arizona and does a lot of work around weight-neutral healthcare and talking to other physicians about weight-neutral healthcare. And welcome to the show, Lesley. Really glad to have you here.
Thanks. I'm excited to be here.
Excellent. So let's go ahead and just start with, I just do a real quick intro about you and kind of what you do, and then how you got into medicine and health at every size. And yeah.
Sure. So I am an eating disorder specialist and health at every size physician advocate in Phoenix, Arizona. I initially got into medicine. I was interested from a very young age. I think I have that caretaking gene, and I always loved the idea of caring for people and being a physician, and so that seemed like a natural fit. In terms of getting into the eating disorder realm and health at every size, I think that really came from my own quest to find peace with my body and to help other people find the same. I think I grew up in a household where my mother had family members who struggled with significant obesity. And so she came from a place of fear and caring in terms of concern about what I ate and my size and her own body image. And I think as a child growing up, it really made me in tune to kind of how much time and energy and effort people spend with those thoughts and concerns. And is it possible for us to live a life where we are more at peace with our body and food and can take that time and energy and spend it elsewhere? So that's kind of why the Health at Every Size movement really was a natural fit for me and kind of my medical career.
Awesome. When did you find Health at Every Size? Like, when were you first introduced to it?
First introduction. Wow, that is a good question. I will have to think about that. I think it's definitely been within the past 10 years or so that I was first introduced to it, and kind of, over time did more and more research and really was excited about this as a opportunity to help everyone, but in particular physicians, kind of move past what I call has been the finger wagging approach to patients that struggle with issues regarding their weight. I think I was getting so many patients that were coming to me that were telling me, you know, I went into my doctor for a broken arm and all they wanted to talk about was my weight, or you know, different things. Like I just was naturally having a lot of those patients gravitate towards me, and you know, started learning more about health at every size and how to kind of incorporate that into our interactions.
Yeah, I end up having a lot of patients who have had bad interactions and they don't want to go to the doctor anymore.
Exactly. And that's what a lot of research shows, is that, you know, the pushback that I get from physicians often is that, oh, I'm just so concerned about my patient's health that I feel the need to discuss their weight, because it's, you know, clear and obvious that their weight is a reflection of poor health. But then I often kind of rebut that with the idea of, then once patients are shamed and feel stigmatized, they are actually less likely to seek medical care. And when they do, they are typically sicker because they've avoided it for so long because of the prior stigma that they have experienced.
Exactly. I just recently heard an interview with Jeffrey Hunger, who does weight stigma research, and he was talking about how very often, even when physicians recognize weight stigma, they look at it as in such a way that they say, oh, well, I want to, you know, reduce the stigma around weight for my patients so that they'll feel better. And I mean, it's coming from a very good place,
right?
But it is also with the caveat that if I can talk to them about losing weight in a non-stigmatizing way, then, you know, it'll be better and they'll lose weight. Or if I can get rid of weight stigma, then they'll lose weight or they'll maintain their weight, which I kind of think was the thought behind turning obesity and overweight into a diagnostic code, that it would remove the stigma because now it was a disease, quote unquote. But of course, the issue with that is weight stigma and weight loss, weight control are not, they don't really go together at all. You know, like,
right.
If you remove weight stigma, it's not necessarily going to change somebody's weight. It's going to make them probably healthier and make them feel better for sure, but it doesn't necessarily change their weight. And so making the assumption that we're still trying to change their weight actually does not, it causes us not to remove the weight stigma. So it's still there.
Exactly. And that's why health at every size is so brilliant, in that we are focusing on health, and we really take weight as one of our kind of clinical outcome points out of the picture. You know, if it changes along the way, that's not our concern. Our concern is to help that person in front of you, regardless of what their weight is, live their healthiest, happiest life. And how do we help them achieve that? And so that's why I think it's so important for us to get that word out to more physicians, so that they can kind of begin to have that paradigm shift from what we've been taught historically, is that the only outcome that we need to be looking at is a reduction in weight.
Right. And that may or may not be helpful for the individual, regardless. But certainly if they're coming in for something non-weight related, it's not helpful at all. Something I'm curious your response to this. I've been thinking a lot lately about even taking weight stigma and health beyond just making sure somebody's healthy, because and really bringing in the idea that everybody, regardless of their state of health, their body size, their race, gender, you know, sexual orientation, all of these things, they deserve respect and particularly respect and care in a medical setting. So even if you have somebody coming in who is, very obviously unhealthy, and whether or not they want to get healthy, they still deserve to have compassionate care, right? So, yeah. So,
and I think that's in line with kind of like the idea of health equity, is that everyone deserves to pursue their own level of health or lack thereof. But regardless of that pursuit, they deserve respect and access to whatever it is that they need. And so I think that I've seen a lot of that transition, and a lot of, the verbiage around health equity and how do we provide that for people and make sure that everyone is getting, equitable access as well as equitable respect and care. And that's definitely something that I'm an advocate for, and trying to find more avenues to really support that. Because, I kind of give the analogy sometimes, if you have a patient that loves to play tennis, and despite that they're having severe knee pain and they continue playing tennis, I feel that across the board, physicians are still very respectful in that encounter, and they don't give the same level of finger wagging and everything else that they do if, a patient were having some other type of complaint and they felt like the activity they were engaging in that was contributing to it was, in the physician's mind, unhealthy. Does that make sense?
Absolutely. I mean, with that example, if you have somebody who's in a small body who is playing tennis, and their knee hurts, and their doctor doesn't want them to play tennis until they are cared for, right? But they keep doing it. Very often they won't get yelled at in the same way that somebody who has knee pain who is also fat would get yelled at. And not yelled at, I mean, nobody's yelling, but I hope not.
Right.
But that would be like, oh, well, you need to lose weight, and that's the only thing that's going to help. Or you need to exercise, and that's the only thing that's going to help, which is kind of ironic.
Right.
And so that it's the same problem potentially, or even if that fat person was also playing tennis, right?
Absolutely.
And wanted to keep playing, that might still, or it might even be that the physician will have them continue to keep playing even if their knee is not doing well.
Absolutely.
So actually encouraging a behavior that could be detrimental to their health, which they would not do in another case. And this is something I see with eating disorders all the time, where we have, people who are in very small bodies who have, say, anorexia or a restrictive eating disorder, and they get care because there's a lot of fear around them being so small. But then you could have somebody who has the exact same behaviors in a larger body, and they don't get care until much later because everybody's cheering them on. Oh, good, you're only eating 800 calories a day and you're exercising for 3 hours. Yay, good job.
Yeah, it's like it's not even that they don't get care, they get congratulated and get praise.
Exactly. And especially if they're coming from a very high weight, there can be a lot of things that will go wrong before then. And that is what I see a lot of the times with treatment in general. If we're just treating weight, it's very easy to miss things that need to, or just not pay attention to the things that actually need to be treated early on. Because the first thought is, oh, we'll just have them lose weight and it'll go away, but it rarely does.
Absolutely. Well, and I know, even in my eating disorder experience, I can recall a patient once that had diabetes that was severely restricting, but because her blood sugars were improved, the endocrinologist did nothing but congratulate her and give her high fives, and never took the time to ask, well, how did this happen? And why has it changed so drastically? And what's going on with your eating patterns? And it wasn't until I called from an inpatient facility and said, hey, did you know your patient was admitted? And she's like, oh my gosh, I never even thought to ask. I was so focused on congratulating her about her blood sugars, I never even asked what was going on. Right. And I think that we see that so frequently, is that we kind of have this tunnel vision. And that's why I really love being able to provide more comprehensive care and incorporate the mental and the physical when you're assessing the patient to really get a better understanding for where whatever they're struggling with is coming from.
Yeah, trying to take the blinders off as much as possible. I mean, we're all going to have some blinders, but yeah, weight doesn't have to be one of them. So I know you do a lot of talks with doctors, as I mentioned in the beginning, that talking to them about weight and about all of this stuff. What sorts of how do you approach physicians and probably other healthcare practitioners when you talk about weight and health and the importance of having some taking weight out of health?
Well, I inevitably have to put the dreaded O word in my talks, and I usually put it in quotes, but I have to put the word obesity
Mm-hmm.
and in order to pique their interest.
Mm-hmm.
So oftentimes they'll come and hear me speak, especially if they see like, oh, a new approach to, managing obesity or the war on obesity. They get very excited, like they think it's a new drug or a new, I don't know what. And so they get very excited and they come. And then I, kind of introduce this idea that, yes, how about let's have a paradigm shift and approach patients from the health at every size approach. And oftentimes, I think as time has gone on, I get more people shaking their heads in agreement, and especially if it's a multidisciplinary group that includes like dietitians and psychologists and physicians. But it's still something that their initial response is they don't want to hear it. They don't believe that it could possibly be true. And they're very skeptical and even occasionally angry at the idea that this would be presented by a physician.
That's interesting. I have had similar experiences when I talk to groups, and I find it interesting, especially when when you do the research and go in. But I find that sometimes just talking about patients' experiences can be helpful, not always, but and one of the things that I've noticed is that mental health providers seem to be much more on board with this, and I think a lot of that is that they're seeing the results of what physical healthcare providers are doing. And sorry, go ahead.
Oh no, I was just saying absolutely. I think that even one of the responses that I got yesterday was, believe she was either a psychologist or a dietitian, and it was at the VA hospital, and they have lifestyle like modification classes or something. And she said that it's interesting because they do kind of like a disordered eating assessment of the patients at the beginning, and then they do it at the end. And when the outcome that they're helping the patient to achieve is weight and weight only, even those people that came in not endorsing any disordered eating behaviors at all, when they got reassessed at the end, they were starting to show disordered eating. But if they made the outcome that you were looking for, increased activity or decreased blood pressure or decreased blood sugars, they did not see that same correlation. That was a really great example of how just by introducing weight as a goal that we are shooting for can start in people that really had never had any issues, start this disordered eating or disordered eating thoughts.
That is fascinating. I mean, I know that Linda Bacon was part of doing a study about with similar idea, that they had one weight loss group that they talked about weight loss, and that was the goal, and then another group where they talked about healthy habits, and the group that had the healthy habits ended up keeping them and doing them longer and having better results than the group that lost weight, and both in the end nobody lost a significant amount of weight.
Right. And I think in that same study, the people that spoke about healthy habits, their weights were more static, where the
Mhm.
other group, they lost, but then they regained. And
Yes,
ultimately, like you said, it was a net no change.
exactly.
Um, so, yeah.
Yeah,
And I think we don't always talk about the psychological impact that can have, of
yeah.
someone who's maybe um, already having struggles, be it anxiety, depression, or whatever, body image, and then they either aren't successful losing weight or they lose weight and then regain it. And then all of a sudden that brings up a lot of negative emotions that maybe weren't there previously,
Mhm.
versus like just focusing on trying to be happy in the body that they're in, versus
Mhm.
this idea of searching for this holy grail and, oh, you achieved it, and oh, now you failed because you're back at your baseline weight.
Right. And that the psychological stress of that weight cycling is pretty intense for a lot of people. And I feel like if you haven't really been through it, then it's difficult to understand how hard it can be, because you end up blaming yourself all the time. It's not that your body's trying to live and trying to survive, and that diets and calorie restriction don't actually work long term, but the assumption is that you've done something wrong. And then to have your doctor also agree with you and say that you're doing something
Yes.
wrong um, can be doubly devastating. And something I don't have any stats on this, but I do wonder with a lot of physicians in general, they tend to be on the thinner side of the weight spectrum, I suspect, at least a lot of the ones I know. Not everybody, of course. But I do wonder if there's a lot of pushback against the weight thing, because you end up having a lot of people who are naturally slimmer, and so they've not had that experience of significant weight loss and weight gain and struggles around that. Do you know of any information around that, or maybe I'm just like talking? Just,
No, I don't know. I don't have any specific stats, but I think anecdotally that's the case. And I know physicians that um, have that live in larger bodies that feel even more of the push to do some type of intervention, because they feel like they are not necessarily being taken as seriously, or again, there's this assumption of, how can you talk to me about my health when you are unhealthy based on your size? And so that I think that there's a lot of kind of professional push to, do some type of intervention, frequently surgical or something else, because it's almost seen as like you need to do this for the profession to be able to maintain your credibility.
exactly, which is really sad, because those are the folks that would have the most empathy in the end
Exactly.
with their patients, if they were able to say, you know what, I'm not going to worry about my size, I'm not going to worry about my patient's size, we're going to be on this health journey together. And then the physicians who, through no fault of their own, I'm not saying it's their problem, but if they haven't had any issues with their weight, and I don't really count like minor weight gains and losses, because if you're kind of staying within your set range, I don't really count that. Um, but if you've never experienced that, then you don't really have that strong understanding of what it's like, and so you might, not be able to really understand when you have a patient who comes in and they're like, I'm trying so hard, and I'm not losing weight, or I lost weight and then I gained it back, and I'm doing everything I can, and I'm so stressed, and and then a lot of times people will jump to bariatric surgery or something that causes its own problems later. That being able to have that empathy might be able to allow people to treat people in a different way.
Absolutely. I know that I have a physician friend who is a pediatrician, and she's a big advocate for this idea of health at every size. And she herself lives in a larger body, but runs marathons incessantly and does all kinds of great things. And she really likes to show her patients, look at me. I am in a larger body, but I'm still doing all of these amazing things. So you shouldn't let that be a hurdle for you. And so she really tries to use that as an opportunity for inspiration. And I think she really can, be empathetic with the patients that she is serving. And so I definitely agree with you that it's helpful when physicians come from a place of understanding.
Absolutely. Another question I wanted to ask you, like another topic, I feel like we're kind of jumping topics, but that's fine, is that we started talking a little bit about the responses that you've gotten. What are the major challenges that you get to weight loss beyond like, well, obviously people need to lose weight because it's bad for us to be heavier. And kind of how do you respond to that when those challenges are brought forward? Because I imagine you get the same ones over and over.
I do. I think, just giving the talk that I gave this week as an example, there was a physician in the audience who is over the bariatric clinic there at the VA hospital. And so the focus there is very much weight centric, looking at interventions and mainly just looking at the weight. And the idea is that you have to do this because patients have all of these different health complications that go along with it. And if we don't focus on their weight, they're going to die type of a thing. That's usually the approach that most physicians come to me with.
Which is terrifying for patients. I mean, just
absolutely,
terrifying.
Absolutely. It's very terrifying, especially if they, have had family members or other people that have struggled. It's just, it feels like you're a walking time bomb. And I think that the way that I really try to approach physicians is let's run the tape, let's look at the historical data. And we have been using this weight-centric approach now for years, and there is no evidence to support that it is helpful. And there is no evidence that supports long-term, positive outcomes globally. So why not try something different? Why not do a paradigm shift? And let's look at all the potential harmful effects of weight stigma, of all this other stuff. And so that's kind of, my baseline approach that can sometimes maybe give them a reason to pause, because I don't think anyone can argue with the fact that the weight-centric approach to date has not been successful.
Right. I think a lot of, not just doctors, but a lot of people think that they're like, yeah, it's not working. All these diets aren't working. It's because we just haven't found the right thing to make people smaller permanently.
Exactly. And so it's the idea that goal in and of itself is probably not what we need to be reaching for. And let's look at, because once again, they're coming from this place of the reason why I'm worried about your size is because it is negatively impacting your health.
Right. And
so we have to dial it back and say, if health is what you're really worried about, why don't you just focus on that and let the weight part go by the wayside?
Right.
And, go ahead.
Go ahead. No, go finish what you were saying.
So that's all. I was just saying that, that's kind of the way that I try to approach it with them, because again, if you're claiming that that's what you're so worried about, then why don't you just focus on that thing? And I asked them to, really look at, I even had some physician groups do like different questionnaires that try to assess their own fears and phobias and ideas about weight, and really be somewhat introspective to say, hey, maybe the reason why I'm so focused on this is because I really do have some fears. I really do have some negative thoughts about it. And that's why it's easier for me to focus on this.
Right. Do you think that is one of the main barriers that physicians have to moving away from the weight-centric paradigm, or are there other reasons as well? I mean, I think that's one of them, but
I definitely think that's one of them. I think it really comes from the educational aspect also. Like, as we mentioned before, in medical school, this is never really introduced. The only thing they talk about is BMI. Most physicians have absolutely no idea where BMI even came from.
Yeah.
Or the fact that it, developed by an astronomer in the 1800s. I don't know how many medical evaluations I'm doing on patients based on 1800 technology that was developed by an astronomer. Like, it's just not happening. And so when you really try to like peel it back and look at and dive into the data and really educate them on how flawed it is, maybe they will be more open to this idea. But I think for right now, BMI is just a shield that people like to kind of hide behind, if you will, versus dealing with kind of the bigger picture issues.
Yeah, I mean, this is something that I think about a lot because the research is out there. It's been out there for a very long time. And even if you look at obesity research that indicates that, that shows correlations, which we know are not causations, between higher weights and different diseases. And of course, they don't always take into account weight stigma and lack of access to care and all of that stuff. But a lot of the times people will point those out and say, but look, this study says high weights are bad. And then very often, if you look at it with a critical lens, you discover that it's not exactly what it says. And, here are the flaws. And really in the end, it kind of proves again that weight stigma and high weights, or weight stigma can cause many problems, and then high weights aren't necessarily any worse on their own. And so, I think about that a lot, and I think, people, when we have all these studies, I guess I still have a hard time understanding why, with all this information, we haven't had the big shift yet. I mean, I think it's coming, but kind of what's taking too long?
Yeah, well, and I feel like people, one, they tend to believe what they want to believe. So even if you are able to present them with data that maybe contradicts their thoughts, they still hold fast and true to their ideas. For instance, the talk that I gave this week, one of the questions was, well, I don't believe that it's true that you could be healthy at any size, because I have never had an old patient that was fat. And so I don't believe that people live long if they're fat, that everyone who's fat dies early. And that was, coming out of primary care grand rounds. And so then I presented them with the data that states, above a certain age, being at a higher BMI is actually protective and correlates with longevity versus being underweight. But again, people really prefer to go based on their own experience or lack thereof.
Yeah, I always kind of want to laugh at the whole, I don't see fat old people, and I'm thinking to myself, like, I've known so many fat old people I don't like, half my family, and then something that I often think about as well is that very often people do start to lose weight as they age, because
you lose muscle.
Yeah, you lose muscle mass. Maybe you're not moving as much. Very often you're not eating as much. I know my parents, like, they eat almost nothing now. And they're healthy and doing fine, but they eat a lot less. They move a little less, and they're still pretty active. And I see that a lot. And then of course there are certainly many conditions that cause significant weight loss that can also cause problems. But so, they might see these older folks coming in who are smaller, but are they asking what was your average adult weight? And were you a larger person before you started coming to see me in my office, as an old person? Like, I have an aunt who lost like 90 pounds over the course of several months, and that's a great deal of weight to lose, but and they still are not entirely sure why. But one of the reasons, I think, is that something was going on and she couldn't eat. And so, but her doctor actually was like, good job for you. And of course I was thinking, why is she losing so much weight so fast? This is very disturbing.
Right.
They did look into it. Obviously they didn't neglect it, but yeah, it disturbed me that she was praised for something that she had no hand in.
Mm-hmm.
And the fact is if she had been a smaller person, losing all that weight might have killed her.
True. And it
So
definitely would have set off alarm bells for the people who were caring for her.
mhm. Yeah. Yeah. Something I think about too, I wonder about too, and I think this probably is true, is that to make that paradigm shift change, doctors would have to acknowledge that they've been harming people by telling them to lose weight and encouraging weight loss and focusing on weight loss. And, I wonder how much guilt comes with that, and how much, because I mean, most people go into medicine because they are empathetic and compassionate and they want to help people. And if you think that that's what you're doing when you have people lose weight, and then you find out that actually, no, that's not what's happening, that can be horrifying, you know?
Absolutely. I think that that's one thing that I have gotten from some of my colleagues that are also friends, and we have talked about this. And I think they're initially somewhat defensive because it's, like you said, it's like someone coming to you and saying that all of your efforts to help someone have actually been harmful, and it is very horrifying for them to think that, and it's very distressing. And oftentimes I think it puts them in this position of wanting to defend themselves versus to listen, absorb the information, and be open to change, right? It's more so about defending what I've done to this point. And I think that's one of the struggles as well in trying to push the conversation forward, is that there's a lot of defensiveness over what their intention has been. And that's another thing that when I am speaking to physician groups, I acknowledge that we are all here because we want to help people.
Mm-hmm.
I just want to introduce you to a way of helping people that's maybe going to feel better for you and definitely going to feel better for your patients.
Yeah. Yeah. I feel like that's a big obstacle, very big obstacle. Let's see. What else was I thinking about when we were talking? Is there anything that you want to say that we haven't talked about yet? I want to say to practitioners out there, or maybe people who are struggling with, how they feel about health at every size, or weight inclusive care, where they're wondering, what if I have? Oh, here's a good one. Like, I've heard a lot of people say that they get concerned, like if you have somebody, there's like, okay, there's healthy fat people, but then there's like a size, and that size is relative, where somebody can't be healthy, and then we have to get them smaller, right? So like if you have somebody who is, bedridden or something, there's that concern, and the people feel justified in doing extreme things to get them to be smaller. What do you run into that at all when people are worried about that?
I do. I definitely run into conversations about that. And I think that's when I shift it back to the whole idea too of kind of health equity and determining what the patient's goals are, right? So if you have a patient that maybe they are bedridden and their weight is extreme and they don't see anything wrong with it, feel very comfortable with that life experience, and they are accepting of maybe some of the consequences that go along with it, I do not feel that it is necessary to go into their home and knock their walls down and do whatever we can to make a shift. Just as we stated earlier, someone that elects to smoke and has data that suggests that that could potentially be harmful for them. I don't think that it's reasonable to go around the smoking section pulling cigarettes out of people's mouths. Do you know what I'm saying?
Right, yeah.
So I think like back to that idea of respectful patient-centered care and really, coming alongside what that person's goals are, how they wish to live their life, and how we can best support them in doing that.
Okay. What do you talk about when people, because this also inevitably comes up, when people say, well, my patients are coming to me and they're wanting to lose weight. Say that person who's bedridden and doesn't want to be bedridden, and they're like, I want to lose weight, but that's my only goal. Like, not health is, another topic. What do you address that when you talk to them?
I do. I will have patients that come in that are interested in losing weight, and I typically try and figure out what the source of that desire is. Is it, because I think that once I do, I'll get a boyfriend or a girlfriend and everyone will love me and, life will be wonderful, or is it because they have some type of physical barrier that they believe, if they were to reduce their weight, that barrier would then go away. So I think I really try to distill it down to figure out what their issues are and whether or not their goals are realistic, and how to support that within the context of overall advocacy for health. Does that make sense?
Mm-hmm.
So again, not having weight be the ultimate outcome, but why is it that you're interested in changing? And is that something that I can help support you in? So for instance, if I have a patient, I've had patients that come in and say, I used to be able to tie my shoes and I can't tie my shoes anymore, and that is causing me distress. Or I want to have more energy to be able to go out and play with my grandchildren. That's absolutely, those are goals I can get behind.
Right.
But just weight loss for the sake of, if I lose this weight, then I have this kind of magical thinking of how it's going to alter my universe. I really try to help them see that there's more to their struggles than just weight, and that the weight loss is likely not going to bring about their desired effect, and how can we kind of delve deeper into their belief that it will.
Excellent answer. Something else that I think comes up a lot is particularly around orthopedics and surgeries with higher weight folks. I hear this a lot. I run into, I can't even tell you how many people I've run into who need knee replacements or hip replacements. In particular, I mean, lower body joint replacements in general, who are denied access basically because of their weight.
Yeah.
It's not even allowed. Even though there's research out there that is showing weight has very little to do with recovery for a lot of people, like with knee replacements or hip replacements. The people with higher weights who have those replacements are still, they still recover just fine. I know I have a colleague who had a patient who has been needing spinal surgery on her low spine, I believe, on her lumbar spine, but was not allowed to get it because of her weight, because it wasn't considered emergent. And then she had the same problem, but in her thoracic spine, but it was considered an emergency. So they did the surgery at her current weight, but they still won't do the elective surgery on her low back, even though it would help her a lot. And it's the exact same surgery that she recovered from beautifully, because they want her to continue. They want her to lose weight, which I thought was insane.
Yeah.
But I wonder, do you ever talk to specifically orthopedic surgeons or surgeons in general too? Because that seems to be an issue, especially around elective surgeries or non-emergent surgeries, even though it might not be elective. It might be that somebody really does need it. It's just not going to kill them right now. And have you talked to surgeons about that at all? I really want to have a surgeon on the podcast at some point.
Oh, that would be awesome. I do, and I would definitely say that one of the fields where I probably get the most pushback, I think that from the surgeon's perspective, they definitely want to minimize what they see as pre-surgical risks, and they are very concerned about doing surgery on patients of size because of fears of respiratory issues or whatever the case may be, and they feel very comfortable denying access to care because of the potential risk that they feel that they are exposing themselves to, and frequently feel very comfortable creating an environment that sends that message that if you are above a certain size, this is not the place for you, that
Right.
you need to be seeking out other interventions. And I don't know if your original question was how do we fix it, but I don't know the answer to that. But I do agree that it is an issue, and I think because it is so across the board, it's difficult to have the data to support the fact that,
Right.
look, patients of this BMI had this surgery and outcomes were still good. I think that that's the type of kind of research that would need to be done to maybe push the needle a bit in that area.
Yeah, I wonder about that too, because I mean, a lot of the times the same patient who might not be allowed to go in and get, say, knee surgery, they have no problem sending them to have bariatric surgery done prior to getting the knee surgery, which always struck me as incredibly insane, because it doesn't make any sense to me, because, you know, starving prior to getting surgery does not allow for your body to be really ready for surgery, and in which case I imagine that your outcomes would be much worse than if you had somebody who was in a larger body but, you know, well nourished and strong, you know, taking care of themselves. Whereas if you have somebody who, you know, is trying to lose an arbitrary 20 pounds, I often will say, because I'll get people who come in and like, my doctor told me my surgeon said I had to lose 20 pounds. And I'm thinking, oh, you can go do cocaine for a while and lose 20 pounds, but that's not going to get you ready for surgery. It's going to make things worse. And so, you know, and especially then going and doing bariatric surgery, where if you're going to be doing another surgery after that, yes, the person is smaller maybe, but, you know, their gut's compromised. They've already been through a surgery, so that might compromise them in other ways. They're not getting enough nutrition, so that's compromising their ability to heal. And yeah, it just makes me kind of crazy, because I'm just like, why don't I just do the first surgery and let those people, you know, enjoy their wonderful life? I mean, I know a lot of times they'll say, oh, if we do knee surgery, you'll just wear it out because of the weight, which is not indicative in the studies I've seen. But then they have no problem doing, you know, surgery on, say, somebody who's an extreme athlete, who will then go back to doing those things that, you know, got them to the surgery in the first place. But there doesn't seem to be any problem with that. Kind of like
Absolutely.
Kind of like the tennis.
It's definitely kind of like the tennis analogy. It's definitely a struggle. The other thing, one of the pushbacks that I've gotten from some surgeon friends too, is just equipment wise. Again, if we're looking at, you know, having like the equipment, the surgical beds, like all of the things that they need to be able to accommodate it, they don't feel like they do. So it's easier in their mind to just not perform that surgery than to seek out facilities and equipment and things that are going to be able to accommodate. And so I think that, again, if we're looking at it from a global perspective, we need to be looking, you know, at medical and surgical supplies and all of that, and making sure that it accommodates people of all sizes. Yeah,
there's a Reagan Chastain, who's a activist in the fat acceptance community, says, and she says, I did an interview with her a little bit ago, and I'm not going to get the quote but directly, but she says basically when you're building a hospital, you're aware that fat people exist. So
Right.
if you don't build a hospital that can accommodate fat patients, then you're basically saying outright that you do not want fat patients to have access to healthcare.
Exactly. And
And
again, that's back to that whole, health equity and access issue.
yeah, and it's huge.
It is huge. I have recently been involved in two kind of assisting people with starting up of clinics and offices. And in both instances, I was trying to provide feedback about structural hindrances to people of size. And in both instances, the rebut was, if they can't fit into what I am providing, then I basically don't want to provide that type of care.
Yeah.
And it was alarming to me, but it's very socially acceptable for people to make those types of comments.
Right. Yeah. And then they wonder why large folks are not getting appropriate health care, and they're not going to the doctor, and they're not showing up until they're in the ER and very, very sick, and then they get, of course, blamed for not getting in earlier, right, to take care of themselves.
Exactly.
Yeah. It's very frustrating. So if you're out there and you're listening, again, I would implore that you look around your clinics, look around your hospitals, and see where you can make accommodations and where you can improve working with people of all different sizes, but particularly those on the larger end of the spectrum. I know I just last year I ended up taking a friend to the ER nearby, and it was in the Kaiser system, so go Kaiser. I've gotten mixed reviews on them in the past. And they in the ER, well, in the waiting room, they had a huge variety of seating, which was great. Different sizes and different heights, and it was amazing. And then in the actual ER, like when we were in the bay, well, when we got in, they did the exam on her. There was like a space for me that was, because I'm large, and so there was like a chair in there that was easy for me to sit in, which was great. And then when they took us into one of the little bays, there wasn't a space. They had one tiny chair with little arms. So and then there was a stool, which I totally stole and sat on while we waited. Even though I knew the stool was for the person coming in to check her out, and I gave it up when they got in there. But then when she had to go in and do a couple of other tests, I just kind of was following around, and they had these stackable chairs that were very wide. I mean, I fit in them very comfortably with room on either side, and they were just, stackable chairs with arms, but they were just wider. And I remember just feeling so great, and I wasn't even the patient, but I just felt so great that I was like, oh, I can follow my friend, or if she were my family member or something, that I could actually be there and be comfortable, and not, because obviously even if you're not the patient, if you're with the patient, you might be anxious because they're sick, and you care for them. So to be able to have a space where you can just relax and sit down and not feel anxious while you're waiting was actually amazing. It made a very long night a little bit less horrible. And
absolutely,
yeah,
experiences like that make you feel welcome in that environment and more apt to return in the future.
Yeah, and they didn't make any assumptions about her weight, because she's also a larger person, and the doctor was a female doctor too, so there were no assumptions about why she was there. They did all the appropriate tests that they needed to do, and turned out it wasn't what we thought it was, so that was good. It was something else that was fairly benign, but I was very impressed, and I thought, how hard is it really to do this? It's not, but yeah. So yeah, I think we covered a fair amount. I'm so glad that you're doing this work. You know, even with the pushbacks, I think more and more people are hearing it. More and more physicians are starting to get on board. So even with the pushbacks, I feel like there's still a lot of good work that's being done, because usually the people who are pushing back are the loudest, and the people who are starting to understand are sitting back and contemplating, which I think is important. And hopefully we can start making some changes, even little things like you helping with trying to help with the clinic.
Absolutely. Yeah, I definitely see that there has been a shift, even if it's slight. Every year, I think I am getting more head nods when I go out and talk about this topic, and more people that are open to the idea that a paradigm shift needs to take place. And I really want to focus a lot of attention on the younger people. I think that it's harder to paradigm shift when you have had 20 plus years of learning one particular model. But I think if we can get more into training institutions, into schools, really getting the word out, not only to physicians in training, but also to young people in general about how to advocate for themselves, I think that that's really going to be helpful in terms of pushing forward and really changing the landscape of the medical community and how it views size and the role that it should take in supporting someone's health.
Agreed. And I think it is important to start in the medical schools as well, just having, so if medical schools can have more patients to work with who are larger, or, practice patients to work with who are in larger bodies. And I know I ended up doing a lot of exams on very small people because all my colleagues were very small. But then they get a chance to do exams on me and have a different experience. And then I know I've said before, I unfortunately have ended up doing a lot of my own training in this on my patients, because I just, having to learn to work with different sized bodies and different abilities and movements and all that kind of stuff. And I wish I had longer to do it in training. And certainly if I had, and this is nothing against any of my teachers, but, they also were not trained in that. So, yeah, it can be very frustrating. And I think that with the surgery stuff too, I think that if, we have the ability to do major invasive surgeries on very large people. Like, we have the equipment, it exists. Because we're doing it. We're doing bariatric surgeries. We're doing other surgeries on large people as well that are emergent. So we have the ability to do it. And I think surgeons need to, experience that and learn how, and have those tools available. And I'm sure that there's probably stuff that we have to do around malpractice and stuff too, but that's a whole other topic. But yeah, yeah, that's part of my goal. And honestly, just having more physicians to refer to. I'm pretty protective of my patients, especially my larger patients, and very often I'm not sure who to send them to when I need a specialist, because I'm not a specialist.
Agreed. I think building those networks is very important, and also, helping to fortify our patients to advocate for themselves. If you are sending them to someone and you're not sure about how they're going to be treated, them getting to that place where they feel comfortable speaking up on their own behalf.
Yeah. Most of my patients are pretty badass, if I may say, and I think having me to come back to can be helpful, knowing that even if they have a bad experience, they can come back and I'll, help them and we can work through it a little bit. But they also report back to me, like totally. They will come back and they will say, that this experience was amazing. Put this person in your list. And,
your Rolodex.
yeah, and then, or this person was awful. Make sure you never ever refer anybody, bigger than a size 2 to them, because they're horrible. And then I unfortunately have run into a couple of specialists myself last year one specialist that when I needed it, and it was horrific. So I've been super fortunate to be able to surround myself with doctors who aren't trying to change my size. So that was a surprise. Not really a surprise, but it was uncomfortable. So, now I have that specialist that I know I can't refer to. So yeah, if you're out there, doctors, and hearing this, and you're on board, and you want people to refer to you, make it known, and people will come. They really want to feel safe and cared for. Yeah. Anything else you want to say, Dr. Williams, before we sign off?
No, thank you for the opportunity. It's been awesome.
Yeah, I really enjoyed talking to you. And again, I cannot say enough how glad I am that you're out there and doing what you're doing. It's really important. Do you want to go ahead and just let us know where we can find you? Online?
Absolutely. Yeah, you can find me online at Lesley, Lesley Williams, MD.com or www.medicalgroup.com. I'd love to connect if you're out there. And I just really appreciate the opportunity to talk about something that I'm so passionate about.
The theme music was composed and performed by Galen Davis. Cover art was designed by Stacy Bias. Administrative help for this episode was provided by Paige Carlson. If you enjoyed the podcast or learned something new, please subscribe, as it helps amplify this important message. Also, please feel free to share with friends and colleagues.